Hello, welcome to the Diabetes Annual Review presentation. My name's Nicola Peltel. I'm a community matron with the Darnall District Nurses. So first question, why do we do the annual review? Firstly, for QOF, the GPs get paid for us doing it. We could also look for changes, worsening of condition when we compare it to the previous review. Use it as an opportunity for patient education, to go over sort of dietary advice. Assess whether they need any specialist input from the diabetes specialist nurses. So, the main sort of areas of focus that the DSNs look at are these 9 care processes. So first one is blood pressure, so ensuring that all diabetics have a target of 130 to 80. Lipids, ask matron or GP to review the bloods to make sure they're within range. The HbA1c, diabetic nurses say 60 to 70 is an acceptable range for the patient group that we see. BMI, is it normal, is it high, is it low, do you need to do anything about it? Smoking history, do they currently smoke, are they an ex-smoker, do they want any smoking cessation advice? Creatinine, looking for the sort of renal function. Has the creatinine suddenly gone up? Not expecting to continue to interpret these results, but just acknowledge and be able to let the GP know if somebody's creatinine, say, has gone really high. The ACR, so that looks at the sort of renal damage. Less than 3, it's okay. If it's 3 to 70, you need a repeat sample to confirm that. And the feet. Have they got healthy feet, good fitting shoes, etc. And the digital retinal screening. Do they attend? If not, why not? The GP can refer them. So, HbA1c, why is it important? So the normal range for non-diabetics is 19 to 47. An acceptable range in our patients is 60 to 70. Sometimes having a slightly higher HbA1c can outweigh the risk of hypos. It's sort of looking at what the blood glucose levels and the HbA1c are sort of both doing as an overall picture. So, as general guidance, if their HbA1c is less than 54, please test the matron or the GP to review the medication. It's likely that medication will need reducing. In frail elderly patients, if it's less than 65, please task the matron or GP to review medication. Like I said, those high HbA1cs can outweigh the risk of the patient having a hypo, and obviously there's massive risk of a frail elderly person having a hypo. So medication. Something important to note is that if you look on the blood results, if their EGFR is less than 45, metformin needs to be reduced. And if it's dropped to less than 30, please task the matron or GP because it needs to be stopped. Particularly as well, if the HbA1c is dropping and the patient is on gliclazide, there's a high risk of them having a hypo, so it's really important that that gets reduced. You may see people on the DPP4s, which is the gliptins, alogliptin, linagliptin. Also, it needs to be reduced if their EGFR has fallen below 50. If you're unsure, task the matron or the GP. Feet. Please ensure you check all the pulses on the feet because it's really pertinent information to know, and particularly when you're comparing it to the previous review, you can know if there's any sort of worsening in their peripheral blood flow. You should always use the monofilament to check sensation. If you don't have one, get one. I'm sure admin staff would be able to order them. The monofilament uses precisely 10 grams of pressure, and that's the sensation that they need to be able to feel. Touching the foot and asking, can you feel this, is not sufficient to check that. The vibration test, you'll see that on the drop down box. You need a tuning fork to be able to do that. We don't have them. I don't think they're going to be purchased in bulk because they're very expensive pieces of kit. Just ignore that drop down box because you physically cannot perform that test. So please make sure you give all the patients the foot care advice leaflet that's on the intranet, and make sure that you're getting them to check their feet daily and noting any concerns or different, and make sure they know who to contact. Diet. So use the opportunity to reinforce eating a balanced diet. The general advice from dietitians is food is better than supplements. Supplements are not meal replacements, and they should not be given as the sole source of nutrition. So the general advice from the dietitians is 3 small meals and try and snack between meals. Avoid low sugar, sugar-free, low fat, fat-free foods, because if you're eating a balanced diet, you won't be consuming excess sugar. So other ways that they can increase calories if somebody is underweight is full fat milk, enriching food with milk, butter, lots of butter on toast. If they like sort of milk drinks, they can have sort of milkshakes, smoothies, have small portion of soup that you can, sort of add milk or butter or something to. So that's the general advice. It is all on the intranet, and you can print all this off and give to patients. Any concerns about weight loss, set up the nutrition care plan and review it after 1 month. Or any other concerns, speak to your community matron. So sick day rules. This is another really important thing that you need to make sure the diabetic patients are aware of. So for type 1s, they always must continue their insulin and test frequently, at least 4 times a day. They need to drink more than they normally would, so 3 litres of fluids. And if they're not eating, they can replace those carbs with the things listed on here: jelly, full sugar pop, milk, fruit yogurt, fruit juice, and they must check their blood ketones and seek advice if they're raised. Generally, type 1s have a personalised plan. So for type 2s, they should always continue their insulin and follow the above advice with replacing the carbs, drinking loads of fluids. But in type 2s, you don't need to check the ketones, it's not necessary. If they've got diarrhoea and vomiting, stop the metformin temporarily until that's resolved. So, are there any concerns? Have you noticed, sort of a worsening HbA1c picture, which indicates a poor control on oral medication? Have they got really severe symptoms of hyperglycemia? They're really tired, they've lost weight, increased thirst, increased frequency of urination? Are they getting frequent illnesses? Is it just one infection after another, and nobody seems to have picked up on any sort of pattern? If any concerns about any of those areas, please task your matron or ring the DSNs for advice. If you've got any questions, please email me and I will compile a frequently asked questions sheet and disseminate it to everybody. Thank you very much.